Okay, so this is looking at domestic violence with neurodiversity. It's perpetrators and victims we're looking at today, because obviously it goes across both, and sometimes you can actually have a case where you've got neurodiversity in the perpetrator and the victim as well. It can get very complicated. When going through this today, there's discussion points which I'd encourage you to write thoughts in the chat. What I've tried to do is put together some cases. They're essentially a mishmash of cases I've come across, so none of them are actual fully a case, because I've obviously anonymised things, I've changed things about it, but what I've tried to do is also remove some key details, because I want it to be something where you can kind of think about it if you had a referral through in your service, because obviously there's going to be, I expect there's going to be quite a wide variety of people on here. Okay, so let's just get that to move. Okay, so I've got a few key learning points. I've just kept them quite general for us. So I'm Kate Ceney-Pratt. I'm a specialist nurse practitioner. I'm a registered learning disability nurse, but I'm also a nurse prescriber as well. And I work in the neurodevelopmental specialist service in the NHS. So it's for our services for 18 plus, but I've worked with transition age groups as well, younger people, and I prescribe ADHD medication. But obviously what I'm looking at here is I've had previous roles as well, so I'm obviously looking through some hypothetical cases here as well that extend beyond ADHD medication and people with ADHD. Okay. Right, basics. What's neurodiversity? So as you can see here, we've got quite a wide spectrum here, and this isn't an exhaustive list. These are the main ones that tend to come up. But we're even going as dyslexia, which some people do tend to miss, because obviously there's a huge difference between autism and dyslexia, and there can be a huge difference in difficulties, but it is a neurodiversity as well. But the difference being, when you're actually looking at it from a healthcare point of view, is things such as dyslexia is classed as a learning difficulty, not a learning disability, which is often confused, particularly because if you look at, say, American literature, they use the titles interchangeably. But in England, actually, it is different. Hence my registered nurse with learning disability qualification. It's for that's for people with an IQ below 70. Is classed as a learning disability, but there is more to it than that. It's functional impairment too, but just to kind of keep it quite basic here, that's what you refer to there. Dyslexia, learning difficulty, and also isn't diagnosed in healthcare. It's not a diagnosis in that sense. It tends to be done by an educational psychologist. So quite different. Now a lot of cases that you kind of come across, and certainly the ones I'm kind of talking about more today, be where you've got sort of suspected or diagnosed autism, ADHD, Tourette's syndrome, sensory processing differences. They do tend to crop up more, found, but we do want to include as many as possible. This is key message that I'm going to be keep repeating to you. It's the fact that actually vulnerability is more to do with the world the person's living in the fact that the standard, the sort of go-to easy one to think about is when you think about physical disability, someone that's mobile and in a wheelchair. They're only going to have a problem necessarily getting in to access an actual healthcare setting if they're physically sat outside in their wheelchair and all they've got is steps to go up. It's that's the very basic analogy there, but you can apply that to lots of different settings. Okay, and you can have, there's certainly a very big issue with regards to neurodiverse individuals being able to access health and social care. For instance, if you've got someone with situational mutism and they're expected to call up somewhere, or you've got someone with Tourette's with motor issues and then they're struggling to type and they're trying to email or fill out a form, there's lots of barriers you can have, and not everyone has support there. A lot of the cases I work with don't tend to have good family support, so there's lots of problems there. Now with domestic abuse, I've actually very recently responded to another professional, another service regarding this, because I am noticing as well that there's some misunderstandings on what domestic abuse is. People have a kind of find it quite easy to understand the physical, the sort of hitting, punching. Sometimes they miss restraining. There's also the bits that I notice that tend to get missed as well is chemical restraints, and that's not just in healthcare settings. If you're someone, girlfriend or boyfriend slipping the partner a sleeping pill because they've just had enough of them at the end of the day, that counts. That's still abuse. You've got the one that I noticed when I've kind of written this that I wanted to talk about rather than, yeah, I'm sorry, I've just seen in the chat the French case, yeah, yes, can't remember the lady's name, the one with the husband and the sexual abuse, but there was way more than that, wasn't there? There was a lot of controlling behaviours and also slipping of tablets. Now, yeah, the bit that I wanted to talk about and just add in here because it falls under a few categories. So when you've got the stereotypical case I have usually is an adult child living with a parent and them going around punching walls, not as a sensory feedback thing, punching walls to intimidate. It's physically violent to maybe not actually at the person, but it's also especially they're causing property damage, so it's also impacting on finances. There's a wider picture, and that's one I've noticed gets missed. It doesn't. I often notice I have referrals come through saying that they think that certain medications or therapies will sort that, but they've not actually looked into why it's there. And sometimes if I open up the case, I then find it's domestic violence. So we've got quite a broad spectrum here, and I want you to think quite broadly about it, start questioning whether things are domestic violence. Now, not everything is necessarily, but you do need to think about the drivers behind it. And sometimes, like with the punching walls, you could still find that it does fall under domestic violence, but the reason for it requires a very different approach, more of a therapeutic one for the perpetrator, because actually it is something to do with, say, a learning disability, but they are still being violent and they are still being intimidating. So you just need to think about it in both ways and safeguard accordingly. Okay. So vulnerability factors. Now remember, like I said, that it's not the neurodiversity that makes you vulnerable straight out, it's the environment. Okay, so you could have someone who can't speak properly, like I mentioned before, but if you actually worked a way around that so that you could actually go, and I've used techniques with people before, I've drawn out things, I understand it's a skill, not everyone knows or has confidence in that, but the fact is sometimes it's something that has to be learned to do with the person. But if you think about ways around it, that person can suddenly communicate. Okay, but I appreciate that's easier said than done in a lot of cases, but sometimes you just need to reach out for that support. So social and communication differences, you could have situations where the person doesn't really stay on topic, goes off on a lot of tangents. There's a lot of problems with them actually understanding, so it's called receptive communication as well, them understanding you. And sometimes if you pay attention to the conversation you're having two very different conversations. And I've come across multiple, particularly find it through emails, because I've seen professionals and patients not realise they're talking about two completely different things because they've both misread each other. We've got so increased trust in others. That's not always going to be the case. You could have the opposite issue where someone's completely not trusting anyone because of lots of bad experiences. But think about people that perhaps can't kind of judge other people's intentions, right? And they've got this sort of naivety, but they don't necessarily realise that, and they do kind of implicitly trust people when actually perhaps they shouldn't, and they're being misled, and they don't even realise in those cases that they're usually being abused. Economic vulnerability and dependence on caregivers. Now I'd say that's more prevalent as well, because certainly economic vulnerability is a big one. It correlates with health and social inequalities, which correlate with learning disabilities, with autism, with ADHD. The research is out there for that stuff. It also correlates with your geographical location, and that more people requiring care in this sort of way tend to be in lower income communities. There's fewer job prospects. There's a lot. That's a whole other session in itself, to be honest. But then in that case, they tend to be more economically vulnerable and more, if they're going to have someone sort of abuse their financial income, it's going to affect them even more potentially. But that's not to say you can't be abused if you're very wealthy, because that happens too. Now, like I said about the trust in others, it can be thwarted by experiences of bullying and exclusion, which unfortunately is another prevalent issue. And social isolation can apply to any of the neurodiverse population, but the one that springs to mind for most is usually if someone's autistic and prefers to have more time away from people socially. That sometimes can then start manifesting as a social anxiety as well, which I've seen enough in people with ADHD as well, and people that aren't actually neurodiverse. But I think you've got more vulnerability with that if you struggle socially. Now, with these things I've just spoke about, consider the impact of those sorts of issues. You could end up with low self-esteem. Memory problems, that's quite a big one with ADHD, I'll point out. Also dyslexia. Poor organisational skills. These are mainly relating to executive functioning skills, which is kind of a cluster of skills that we use to try and kind of organise ourselves, remember to do things, break tasks down, do it in the right order, the right sequence. If you've got issues with those, you're more vulnerable really to being triggered. And I think I'll go on to that in a moment, because that can then facilitate abuse. Okay, so what I was just saying to do with triggering. If someone's got sensory needs, just have a think about how you could use neurodiverse traits to abuse. So, okay, so yeah, you can make a sensory overload. I have this. It's very difficult, because the thing is, what can happen is that person doing it sometimes can be posing as the hearer, and also they can tend to make the person think that it is their fault, that they shouldn't. The perpetrator can make the person think that they should not have to put up with that making adaptations, making just generally having some give and take in a relationship isn't something that they should be doing, and it's wrong that they have all these requirements. And actually it's basically using the needs of the person, those needs as part of their disability, as a reason for abusing them. So I've also come across people, I've heard this quite a number of times, about someone being confused, and actually if I speak to them, they're not. It's usually if they've kind of, if the perpetrator's aware that the person's revealed something or hinted at something that's abuse, they want to actually try and play it off as being their neurodiversity, their poor memory, for instance. And special interest, people don't spot this one very much. So if you've got someone, for instance, who's autistic, it's applicable to others too. If you've got interests that you're really, really intensely into, and actually it forms part of your well-being, if you don't actually engage in those interests, you can feel quite low, anxious, can make you quite unwell. And the perpetrator can deliberately thwart those interests, stop them from doing it, basically. It's abusive. Now, that's not to be confused with something, say, I don't know, someone's really into rugby and it happens to be that the carer couldn't take them that week because of an actual circumstance that happened. That's not to be confused. That is a genuine, a genuine issue where it's just not happened that week. But if the person that you're working with does disclose that and they think it's abusive, then you do still have a duty of care to just look into it. So but sometimes that can happen if someone really doesn't understand what abuse is. and isn't, and if their expectations are a bit too high for the carer. Okay. So the coercive control element, I've deliberately highlighted because I find it's one of the most prevalent ones. It's also, when I did a training course quite some time ago with Equation, they highlighted it as being one of the main precursors to homicide. Whether that statistics changed, I'm not quite sure, but that was something I was told by Equation quite a few years ago now. I've always kept it in mind because the problem with coercive control is it's not as easily evidenced. So if someone is being controlled and they go to the police, that's far harder for the police to actually investigate and collect some evidence of than if they've been beaten up, essentially, because you've not got bruises and things to show it. So, and if you look at these things, what can happen sometimes is the person so used to being controlled that when you actually receive that referral, they instantly give consent for such and such to be fully involved in their care, and that you should speak through them instead of the person, which you need to check that. It can be very tricky, and it's not usually terribly helpful to start, overtly asking that, particularly because the said person's usually there as well. But as you build up that rapport, there's usually an opportunity to have a little bit of chat directly with the person on their own. And usually if there's a carer that's actually truly supporting the person, they usually do encourage that as well, I've noticed. So I'm not going to be honest that I think with these particular ones, you might suspect things and you might not quite get the outcome you want with it all, but you just still need to do what you can to try and safeguard. With a lot of these cases I'll look at, you're having to work two separate channels at the same time. You're having to take the assumption that the person is playing a caring role and genuinely is a good carer, and also that they aren't, and put some safeguarding in place. And I've literally had to write notes with both at the same time and having to explain that I'm doing this and this simultaneously. Someone who's, I can't even do an impression of it because I've seen this several times. The person talks so fast, because you can have fast-paced speech that can be attributed to someone's ADHD, okay? Because their thoughts are going really fast. Times the speed up several times if someone's really stressed. You've got that. So if you think of the recipient, this recipient can't really make sense of what that person's saying. That person's also giving lots of accusations, but because their thoughts are going so quick, they're not following it through. They're not saying, well, the internet keeps switching off, and I think it's them because it's timed exactly when I'm with my son, and when I have a rigid routine, and they know that I watch this at this time with them, so they're sabotaging the time I have with him. And also they're able to log into the router. If you have all that there, that makes sense, but that's not what's being said. It's just lots of accusations, and some services, well, a domestic violence service is clued up on what can happen, but the thing is if they're not actually, if it's not making sense, they're still going to think, hang on, this might be mental health. It sounds paranoid, could be psychosis. That's generally where I find things start. That's the query that tends to come through. From services. Okay. I can see a query about social services, but we're not on social services yet. Now, when the case comes through, we've got to have a think about what I'm trying to focus on here is helping you try and establish what is true and what isn't, for you to kind of work with someone in whatever capacity you're supposed to be, so that you can kind of advocate for them. Speak to that domestic violence service, mental health service, wherever, that they're kind of not getting access to try and help them get access. Because even with social services, if you were to call them, if that person was to call them up, they're going to be quite confused at what's going on. Okay, now it's easy for me to be saying, to kind of show you this, because I'm presenting this was happening, but at the time you don't know if this is happening or not. You don't know if this person is having a psychotic episode, for argument's sake. You don't know what's going on. These are the sorts of things to try and think about here, because you've got to kind of look at it from both mental health side and domestic violence side while you're figuring this out. Now, this is the sort of thing that we were ending up with here, was you can have things like people thinking that they're misinterpreting events, misinterpreting what's being said. What's key in helping is trying to break that apart. So what I was doing, what I would do in this case would be start pulling out points with the person. So if they're talking to me and they're going at 100 miles an hour with things, you need to kind of even sometimes have a notepad and pen and just make a point and go, right, so this point, can we just talk about that a bit more? So why do you think this is happening? And it's a lengthy process, but you do, if something's actually happening, you do end up with good logical answers. And then you've got that documented, and that can be sent to different services to get the support in place. Something you need to consider in, say, for this particular one, is some of the stuff might sound far-fetched, but you do have location tracking. It's available on smartphones. Now, some things have changed a bit more recently where, for instance, Google sharing will periodically tell you that you're being shared, you're sharing your tracking, you're sharing yourself with your location with someone else. Now, you have to think as well that sometimes the person is kind of being threatened into doing that. Other times, it might not be through something like that. It might be something more covert. It's quite shocking what sort of apps are available now, and I'm going to show you one in a moment. The key thing usually is the perpetrator being able to get hold of the person's device. If they go to the toilet, whatever they do, just leave the phone down somewhere when they nip to the loo, whichever way they can set that up, then they tend to have ongoing access. So it's usually quite easy to log into someone's Gmail account if you've authorized it on their phone, and then you just keep it logged in. WhatsApp is one where people don't realize WhatsApp's one actually. So I'm going to show you in a moment actually how WhatsApp's logged in, so you can actually understand it. It's just some instructions on how to check that whether it's logged in on another device. But let me just show you this particular clip. It's about 3.5 minutes. If you've seen it before, because you've done some equation training, because I know they've shown it in one of theirs, go make a drink at 3.5 minutes. If you've not seen it, it's interesting. Actually, it's really scary. But let's just get that up, because the BBC did one. They showed us this particular app that I think I've come across as well.
Stalkerware or spouseware is powerful surveillance software used to spy on a partner. Once downloaded, it allows someone to see and hear everything a person is doing on or near their phone or computer. According to cybersecurity researchers, stalkerware is a growing problem, particularly for vulnerable women. I've downloaded the software and recruited my colleague Joanne to test it.
You're going to use this phone. This is effectively we'll call it the perpetrator's phone. Okay. And you're the perp. You've got access to everything I do on this phone. We'll call this phone the victim's phone. So if you look at that phone there, that's your dashboard. So you are all set to effectively spy on me for the next 2 days. One whiteboard marker, whiteboard pen, just a black one.
Joe is buying a whiteboard marker.
Oh, okay.
And I can hear it. Can you hear it?
You've got a black one.
That is so bizarre. I can see Joe picking up a bike.
I can also flip between the front camera and the back camera on Joe's phone.
This is quite creepy. I can see where Joe's moving. It's not just updating every so often, it's a live image. It's just gone 10 o'clock at night, so I'm going to try and see his screen now. I think it might be Candy Crush again. I can't just see what he's up to right now, but I can see what he's been doing over the course of the past few hours. There are alerts at the top of the screen for text messages, for social media. So there seems to be a record function where I can go back through all the calls that Joe's made and listen to them.
Oh, idiot. I haven't got an excuse. I think I've been tired or distracted. So Joe, it's fair to say you learned a lot about me through spying. Can I have that back?
Yeah, you can take that.
Thank you. The amazing thing was for me, obviously knew that you were filming me or listening in or reading my messages, but I had no idea when. Nothing happened. The screen stayed blank unless I was playing with it. No notifications, no battery use, but this data was being sent to you all the time.
Victims like Amy, not her real name, say stalkerware is being used as a tool for domestic abuse.
There were just little things that were dropped in the conversation that never felt right. He knew details about my body, how easy I was all the time.
This is the moment Amy found out the truth by accident.
I saw an alert that said daily report on my Mac, and I just had this chill go through me. I stopped breathing for a minute.
The advice from security experts to stop stalkerware being added to your device is don't leave your device unattended. Most software downloads require physical access. Don't use biometrics. Thumbprints can be used without your knowledge. And download security software. Cybersecurity apps can detect stalkerware and remove it.
Okay, so that's an eye-opening one if you weren't already aware of it. Regarding that, that's a little tip. In my experience of that kind of app being used, if the person is accessing that and has downloaded that on someone's phone, they're usually logged into other things too. So assume they're probably logged into Gmail accounts, for instance. That's a big one, especially for Android phones or equivalent for Apple. Now, what I've come across then is the person, I suspect, not realising that they've got the automatic upload enabled. So when they take screenshots, which they might well do from that app of the person's location or what's been shown through their screen, it's uploading to the victim's Gmail photo account. That's how I figured out one in a case. Let me just show you the WhatsApp. It's not a video. I just did a little lovely AI overview. Now I know this one works, and the fact that I logged into my own WhatsApp on one of my laptops. Now what I found was I had to authenticate it, give permission the first time, but then every time since then, my kids are going on the laptop, WhatsApp comes up. And that's not a problem for me, but I can see how that can be used. And I did once have a query about that where not one of my cases, but someone had asked me if it was possible to do that because it had it dismissed by police, because someone had suspected that someone was using their WhatsApp, replying to messages as them because these aren't my messages and this isn't how I would write. But that particular police department wasn't aware of that and thought, again, this doesn't happen. So don't assume, please don't assume services are always clued up on these matters, because if they've not had the specific training, the technology is moving so fast, they're not always aware of it. But the problem is them not having that curiosity to question whether they're actually right and whether it is possible, which is one of the things I'm really trying to install today with you. So that this is a way of, you can look, if you want to know how to do it, just look at my Google search. This is all you have to put in. It helps you check if you've got a device that's logged into your WhatsApp that you weren't aware of. Okay, so that's something. I mean, you can allow, obviously, domestic violence charities are, in my opinion, much better at at checking all this stuff. I'm not suggesting you go off and do that with all your patients, but there's the other thing that perhaps you would feel confident just showing them how to check it. But get that domestic violence referral in as soon as you can. Okay. So I've just been talking about things being dismissed, and I can see the thing about cybercrime department. I've not got links. I know that there are departments, but I'm not sure exactly where they sit within the police. I've not currently found the links for that. But I think if you're a practitioner working with someone, or social worker, or whatever your role is, if you're working with someone and you think, hang on, no, they've got that wrong, speaking up for the person is usually all you have to do, because I've just shown you very quickly that some of this stuff is actually feasible. So you can quite easily Google this stuff and say, no, look. And sometimes I literally end up doing that. So have a little think about how this can be, how David's difficulties could have caused problems. Think about it in the context of your service. I can see loads of you already been putting stuff in, which is great, in the chat, so you've already been thinking about it. But if you've not so far, just have a little think, try and apply this case to it coming through to you, because remember, this case, like when things like this come through to me, I'm not hired as a private investigator to figure this out. It's for something medical, something nursing wise that I need to be doing. This is stuff that I pick up on and then manage alongside it, but that's not what the referral's for. Okay. Oh, and also do let your manager know. I'm sure you already know that, but the thing is, it's not just about letting them know that there's this issue happening, but also the time it's taking you to deal with this, because it's quite time consuming. So we've gone through some of this, I think, already, to do with like how the person's neurodiversity, how they interpret things, can affect whether they spot the abuse. Because if you think about someone who's, well, it's not always even just neurodiversity, but let's say if you've got someone with trauma that's witnessed domestic violence in the past, dad always used to track mum, dad always had an issue if mum went out. To them, that might be normal. They might not see this as a problem. You need to kind of contextualize it. There's sometimes education needing to be done to help them identify that they're a victim. Now, this is just one idea for that. If they're sort of not sure what's going on, if this is domestic abuse or not, but you think it is, but they're not quite hearing you, people don't always take you up on this stuff straight away, but I find just giving them a bit of processing time can, and bear in mind as well, with neurodiversity, extra processing time can be needed. If the person's under this amount of stress, they're going to need extra processing time anyway. I mean, if you've got neurodiversity with it, it's expect them to need longer. Okay. Don't think just because you've not heard back from them on a decision that they're not interested. It could be days, and don't panic about that. Just nicely check in with them, okay? And perhaps even tell them, I'll check in on you in a few days and just see if you've had long enough to think about it. And check which format they'd want you to do that. They might not want a phone call. It might be overwhelming. They might want an email. If you have the ability, you might want a text message, but not all services have that. Bear in mind as well, if you're looking to do those things, you need to have that chat about what a safe channel of communication is. Because if the person's using a Gmail account and perpetrator's logged in, we don't want that. So, but if they do have a safe contact email that they've either set up themselves or family member that is trustworthy, you can go different ways around it. And that's usually something that's needed on well, in fact, it is always needed on the domestic violence referral forms. So if you think about this is me kind of just reiterating to you what executive functioning issues are, because it can be quite difficult sometimes for people don't always know exactly what I mean by that. But if you think about what they find easier, if they do find, like I said about different communication methods, if someone does find actually a phone call easier because they struggle with typing, then you lean towards that one and you find a safe way of doing it. It's also a case of whether they want to record situations, things that they've noticed in a written format, as in pen and paper, whether that's safer or easier, maybe on, if WhatsApp isn't compromised, on a WhatsApp message to themselves, or whether they'd prefer to do voice notes. But like I said, you just need to think about their strengths, what they can do, but then also what's safe, and you need to try and work around that. Okay. Now let me just have a look with this one. Just one moment. There was another link I wanted to show you. Silent solution. Just going to chuck this one in here because not everyone knows this. Now, it's important to give this information if you think there's domestic violence, even if you think it's really kind of low level. You know, you don't think the person's at risk of dying or anything really severe, but you can see something's not right because it could escalate at any point. You don't truly know. So this is a silent solution. Great to show them it. You can even just verbally explain it. Okay, this is literally it. Someone can call up 999 silently. So if they're hiding because the perpetrator's angry, looking for them, they can call them and they don't have to say a word. Now, even if they can't press the 55 button, what I was told is the police will still consider that, because you might not be able to. You might have had to just set the phone going and then they found you. And the phone's still in a wardrobe or something. Okay, they can hear what's going on from the other end, but just reveal, educate people of this, because you never know when it could come in as a crucial thing for them. Okay. Let's get these back on. Consider that they might not always tell you the truth, even as the victim, because they're scared. Particularly if they've had this sort of thing compromised before, where they've told services. And it's not followed through. Now, look, I for my demographic of patients, I tend to actually proportionately have more domestic violence victims that are men than women. I do get both, but there's more that are men. Now, I'm sure this definitely can happen with women, but there is still a bias, and it's very evident to me, because there can be cases where you've got really severe physical, sexual violence, and the man has come forward and they only get as far as giving a statement. That's crushing. That is crushing for them. And there can be instances where there can be accidents happen as well, where there's situations where, like, say the victim's told, I'm going to say GP surgery for argument's sake here, but it's not limited to GP surgeries, but say they've told them about concerns and about the violence, and then when you've got, say, a child in the mix, so that then you've got the perpetrator coming into an appointment for the child, sometimes it can be put across on the child's record and it can be on the screen. You've got to be really careful. I've come across instances like that. So then the perpetrator can see the disclosure. Some trusts have taken steps to try and stop that from happening with the record, to try and keep up with it. You can always ask. Even IT usually knows about this because of it being to do with clinical records and things. If there's actually things that you should be ticking to try and make certain notes disappear. My trust uses Rio. There is that facility there, but I'd say that I would have thought that maybe not everyone's quite so aware of it if they don't deal with many domestic violence cases. Okay. And this is also why in my opinion, why you might find that it takes a lot of different disclosures before we actually get anywhere with when victims are trying to get out of a domestic violence situation. They might not even give you a full disclosure at any one time. It might be quite a while before you get any information from them. Okay. So this is just a kind of little breakdown of what we've been going through as well. But if you're thinking about cases that are open to you now, just consider, if you were suspecting it in particular, consider if you've got any sort of flags there. Okay. If you've got, it can be very hard, in particular if you're in mental health, or even if you're in social care, I'd imagine if you've got someone that's really kind of a very anxious person. But you have to take a step back sometimes and think, well, is some of that because of the domestic situation? What's going on? That's why it's always worth just keep checking whenever you can. Is everything still okay at home? I find though that if you've got someone that speaks more literally, I can start with that, and then I watch for the response, and then I have to explicitly ask. And I often do end up going, I'm sorry to ask this, but is there any abuse happening at home? And I usually then also give some examples. And I just go, I just have to ask. It's okay. I just want to check you're okay. I found people appreciate it, actually. Right. Referrals, when they're coming in, I've just got some indicators here, some things to think about. And I'm going to go on to just show you some slides quickly about some sort of quotes. I've not gone through loads of referrals and literally pulled out quotes. They're just ones that I remember coming across. I've heard other people say. Okay. You need to have a think about the referral. Try and have a look at what the referral's for and what else might be going on. Because again, don't assume the person referring has had the time or even has the full knowledge to kind of think about, is this a domestic violence situation? The common one where I find it gets missed is child to parent, and that could be adult child. Obviously, in my service, it tends to be adult child, but what I've noticed is in those cases, there's usually a history of pre-18 abuse towards parents as well. And that usually is sons towards mums, but it's not exclusive. Think about this. I've tried to do a few slides trying to give it from different sorts of services, depending on what sort of service you're from. So we're thinking more of a sort of family service here, or ones with kids maybe, or so think about stuff that's got this sort of phrases you see that you might go, what's that about? What's this? What's going on here? Bit of professional curiosity is good. Mental health. I do think these are trickier, but that's based on my experience. Because this paranoid one, it really does lend into psychosis quite often. And also, if you've got neurodiversity, if you've got a type of neurodiversity that tends to lend itself more to obsessions, kind of obsessively focusing on things, social issues where sometimes that evokes anxiety, the person learns social anxiety over time. When I say learn it, I mean more in terms of they're struggling socially, and so the way they try and compensate is ruminating over what they've said, what the person said in response, because maybe they can't always read the facial expressions. They're not always sure if what they've said is appropriate. So, but because that's there, sometimes the person can sometimes not realise that actually what that person said to them was abusive, and that because they're always thinking it's the victim's always thinking it's their fault, because they've been kind of brought up being told, well, you have poor social skills. So but the other stuff is if that person's known to ruminate and think that people don't like them, they kind of get that label, and they're quite paranoid about what people think of them, and so then it just kind of gets overshadowed. I've also come across preoccupied with people watching. That I've seen in non-domestic violence situations as well. So think about it differently. Try and think of a different lens. Try and have a look, because it doesn't mean you're necessarily going to act on it there and then. It's if you've had a referral and you're triaging it. If you think, right, I'll accept this referral, I'll be seeing them. Just prepare yourself to ask some of those questions. Think about it differently, just to try and pick up on it from the first appointment. Struggling to cope, I mean, that is common. You're going to get that in a lot of referrals. But I do find neurodiversity is given as a reason for what is actually abuse. And there can be quite a few different phrases put into referrals that make me think about it a bit. Okay. So this is kind of just reviewing what I've just been talking about. Think about whether there's diagnostic overshadowing happening, which is what this is, where you say, well, is there autism? oh, it's their anxiety disorder. They've always been paranoid. And one of the things that I come across as well is this idea that medication must be effective as well, and medication will fix it. Masking can put an awful lot of strain on people that are neurodiverse when they're trying to constantly try and mask to not just fit in socially, but also they might be doing lots of other things to try to just get through the working day. Just, you know, even if they're wanting to go to the shop, but they find it really hard and overwhelming going to, say, that big supermarket, if that's usually a big trigger I found, and so they're trying to compose themselves. Now, that in itself presents an awful lot of stress and can lower self-esteem over time. So when you have domestic violence put in with that, and you've probably got the perpetrator using those sort of triggers against them as well, you're likely to end up with shutdowns, meltdowns, if we want to use that term. I know lots of people, you might want to use different terms, but it's whatever the person uses. But if you might have that, you might have hypervigilance, so that they're always looking at things, they're always really anxious, and they're spotting every single movement around them. Because it's too much. It's too much stress, it's too much loading on them. And if you're going to have a domestic violence situation along with that, I would say you kind of expect quite a lot of these issues, quite a lot of this trauma responses. So I'd even take that as a red flag as well, because you might think, oh, maybe an amber flag, however severe you might think it is at the time, because you might have autistic or ADHD burnout, for instance, or it might be that it's precipitated by controlling behaviours of a partner. Just so you understand what that is, I'm just going to quickly show you. Just one moment, if it will let me, given that that's on top of it. Just want to quickly show you, when we're using these terms, what I actually mean, okay? So the classic example I would generally give for shutdown is a person who's can't cope at all, tends to be on the floor, usually with a blanket over the head or something else, blocking everything out. They might just go in the room and they don't want anyone to come in. It can be lots of different behaviours, but that's also where you tend to find, if there is situational mutism, it might come in there as well. So do listen. It might take a very long time. Some of my appointments are very long, but you need to listen to the story and try and figure it out, what's going on, and ask questions. Think about safety planning. Even if you're not sure if what they're saying is completely accurate, you can put a safety plan in place, that's good. And you can even write in the safety plan you're not quite sure what the situation is at the minute. Keep reviewing it. Think about the accurate records, objective observations. So, you know, if you've got someone that's saying, oh, well, they have it in a text message that they sent, that they did this, they've admitted it, ask if they mind showing you. You might be able to see it. They might even email it you. It can be quite useful. And the dash form, if it's high enough threshold, the dash form, you can actually fill out the MARAC section at the bottom as well. With domestic violence, and it's also used as a referral. Avoid the common pitfalls. We've already gone through some of this, but I'm just trying to give you a more extreme example. But these happen. People are going to easily try and attribute it to a neurodivergence, and you've got to consider the perpetrators in this as well. If you've got a neurodivergent perpetrator, let's say your husband is in this scenario, this doesn't excuse the behaviour. So you could have someone who's being very controlling over another person's life. We kind of move away from drug gangs if we think more about, you've got to put things away in a certain order, you've got to do things a certain way, tea has to be at a certain time, because I really struggle as a person to cope with things not being at the right time of day and not being predictable. There is sometimes quite a fine line between making adjustments as a carer or a partner that's acting in that capacity too, however they want to identify, versus it becoming control, coercive control, because if it's not done that way, I'm going to get really angry. Now, like I said at the start of this, you can have situations where you need to think about it a bit more therapeutically, but you still need to get the domestic violence stuff in there, because it's still affecting that victim. Even if they don't see themselves as a victim, it's going to be undoubtedly causing harm. And so it's, even if you're just referring and then all they're actually accessing, if they access it at all, is someone to talk to, you've got someone monitoring that risk to make sure it doesn't get worse. Because if you start changing things within the household to try and make it so it's not as controlling, even with the perpetrator's consent, because let's say they want to change, they might still struggle and then lash out at points. And if it escalates, you want that service there, really. The issue you've got, obviously, is if they don't consent and if the threshold's not high enough for you to override it. But if you have that dash form already there, completed, then you can add to it and check if it does then meet threshold. That's why it's important to do it at the start. And you need to hold them accountable to it. It's not acceptable. It is not acceptable to start controlling someone to that degree. It's not acceptable to be controlling your partner or your parents or family members' movements because you want to know where they are at all times. And, and you're messaging them if you think that they shouldn't be at a certain place at a certain time. Why aren't you back making tea? That's not okay. And I think you need to have a look. If you're in this capacity, of course, you might not be able to deliver this. It might be that you're sourcing this elsewhere, but you need to be getting more of a wider assessment of what the perpetrator's needs are and how to best target them in a safe way, where you're actually trying to improve the situation, lower the risk, you're trying to treat their needs, but you're also looking after that victim as well. This ties in very nicely with child to parent and adult child to parent abuse that I spoke about at the start, because what I've noticed can happen is you start off with a child, we say, with neurodiversity that has needs, and when they're young, it's very common to, you have parenting classes, you have specialists telling them stuff that's, it's valid. Try and keep a consistent routine, try and work around them, and the parents work so hard at it. But then sometimes, as that goes on, it doesn't really adapt. That child can sometimes become unreasonably demanding, and even if they do need a rigid schedule, the thing is if it's not delivered, they can become violent, and that's not okay. The parents are usually, I've found, quite reluctant to see it as domestic violence. They're reluctant to report it as that, which makes it very difficult for services as well, because they usually, if I'd say the majority do want to report it. There might be a few where they've not spotted it, but that's the situation. And then suddenly what will happen if that's not addressed is that person turns 18 and then they're an adult, and what we're seeing as behaviours in childhood are now criminal acts. And that can be very difficult to work with. It can be very difficult for the parent, very difficult for the perpetrator, because it's now we're under a different framework of law and accountability. But also the risk tends to go up, because that's usually quite a bigger, it's a fully grown adult by this point. And if I'm talking usually sons to mothers, but not always, but then we usually then have a big size difference of big lad, small mum. And that does create a risk. I mean, it doesn't matter really if we've got mum's taller and bigger and more muscular than the son, but it's still domestic violence. But obviously in terms of risk and what could happen, sometimes that needs to be factored in a bit more. So that's one that's missed. It's quite a more specialist area. It still falls under your domestic violence charities, though, the same ones. And consider these when you're actually thinking about a sort of case where that might be the situation, because being a vulnerable person doesn't mean you can't harm someone else. Okay. And finally, if we have a little look at mutual abuse, because also you could have a situation, if we're sticking with parent and child one for just because we've just discussed that, consider as well if it's some of it's learnt behaviours and you've got two-way abuse, but you can also have that in relationships, and you could have them both being neurodiverse and both triggering each other with their own needs and each other's needs and using it against each other, or lashing out because each other's needs aren't individually being met and then they're being violent to each other. Again, it can sometimes provide that therapeutic input as well as domestic violence support and risk assessment and risk management. This is just to give you a little, just a bit of a summary on what to have a look at. Some agencies you could consider. And also what it can look like in child to parent abuse, because it is usually a bit different, and you can have the situation I mentioned at the start to do with a young man banging on walls to intimidate rather than actually hitting mum, but it can then escalate to hitting, for instance, and controlling the whole household, and it's suddenly being seen as normal because it was happening at a young age. Okay. Another one I've also come across in this sort of scenario is the financial abuse, and the fact that the person could deliberately break things and expect parents to pay, demanding money because they're not going to work, and the parent still sees them more as a child even if they're not. And they can sometimes have it where it starts off as anxiety, where the parent is, so they want to monitor the whereabouts, but then it progresses into actual abuse as it gets older, because now it's expected that they not only know where the parent is, even if that's with the permission, but that they dictate when they come home. And these are some of the things that parents can come across. You can come across parents saying as well, if you've got if you're kind of talking to them about it and they're not quite seeing it as domestic abuse themselves. You can have all these sorts of things said, but them still not want to pursue it, unfortunately, to get the support. Right, there's some considerations to have. I'm going to just skip through a bit now because I'm just mindful of time. Okay, I can see there's been some links put in the chat regarding different domestic violence charities, so I'm not going to bring them up on the screen like I was going to because we've already got them in the chat. But I think we're now on to questions.
Oh, thank you, Kate. Thank you for delivering that presentation. We've got a few questions. I don't know if we'll get through all of them, so, but I'll make a start on them. So the first one, I think you might have covered it because it just questions issues with executive functioning. I'm not sure whether that was questioning what is executive functioning, and then you gave an explanation of that. If that isn't what I think it was Sonia that you'd put that in there. If it wasn't what you meant, Sonia, then just please type in around what you were asking about executive function, and then I'll ask Kate. The next question says, you've highlighted how communication differences can increase vulnerability. In your experience, how often do safeguarding concerns become clearer once practitioners adapt their approach and find a method that genuinely works for that individual?
I mean, I don't know in terms of statistics here, but I just tend to find that once you learn to truly listen and then pull out those bits, like I explained, to do with if they're saying I think they're controlling the Wi-Fi, and then they go on for a while, and then you go back, right, have just talk about that Wi-Fi. Why do you think that is? Do they and you sometimes need to prompt and go, can they access the router? Because sometimes that person actually has a lot of understanding about technology, and that's why they know that they could be accessing the Wi-Fi. That then needs recording. Those answers need recording, and that can form that risk assessment. And it isn't, I usually think that it's when you actually start looking at that risk assessment as a whole, go back to it and have a look at it, that you can start seeing, there's quite a lot of safeguarding concerns. I usually, in appointments, will ask the person straight, say, straight up and go, well, I've gone through a lot today. I think there might be warrant for safeguarding referral. I'm going to go over it all first. But if there is, are you happy for me to refer you? And if they're giving me that much information and they're that stressed, they usually say yes. So then I can just kind of use the risk assessment, use the dash form, and I often share it with social care directly. So I think the approach makes a huge difference, because these cases are ones where they perhaps come through as one thing and it turns out to be domestic violence when you actually change the approach, but the people they've seen so far didn't know how to do that, or they just didn't recognise it. I think it's effective, essentially.
Thank you, Kate. The next question asks, it sounds as though some neurodivergent traits can increase vulnerability, not because of the trait itself, but because of how another person chooses to respond to or exploit it. How do you help practitioners keep that distinction in mind during an assessment?
So if you're thinking about, if for argument's sake, use the sensory needs one, because that can be quite, I'd say that's very easy to exploit if you know that someone can't cope with high temperatures and you deliberately turn up the thermostat. Or you leave noises, make sure there's noises they can't tolerate in the background, and then you're kind of inciting them to kind of lose their temper, and that person then is seen as being the person that's aggressive. It's sort of gaslighting that I hear about. I think you need to ask those questions, so you can go into what's your sensory needs, what does that, you normally have to break that down anyway and go through them so the person can help filter that information, the relevant information through to answer it. But then you can ask, like, how is that managed in the household? So like with your partner, for instance, are they helpful with it? Do they sometimes do things that are a little bit triggering? You don't have to be making it sound like you're searching for domestic violence at the time, because the person might get a bit scared by that. You can just go, oh, did they get it right for you? And then you can kind of go into that and just gradually ask a few more questions, and even take the initial approach of, well, maybe we could discuss it with them. What do you think? Or because that's usually then when you might get the response, oh no, don't do that. So that's how I go with it. It's more in-depth questioning about what their needs are and how that's managed at home.
Thank you, Kate. So the next question asks, would there be a risk that professionals focus on how the information is being communicated rather than the substance of what is being reported?
I think there could well be, because I know I kept going on about psychosis, but it is quite an easy one to kind of demonstrate this. With psychosis, for instance, you can have what's called like pressure of speech. You can have it where you might have the conversation not quite make sense, and it's different from going on to tangents. But if someone's kind of focusing on how things are being said and how that sort of narrative's been relayed, it can then be difficult to sort of think about what's being said. And I think sometimes if you do find that hard, because it is quite a tricky task, you're doing several things at once, it's important then to make the notes of what's been said, particularly if you have transcription software, it'd be amazing, but make those notes and then go over them later. Don't be frightened if you've not picked up on it in the appointment to go over the notes and think, oh gosh, they've said this. See them again. Make sure you speak to them again about it. So don't just leave it and think I should have dealt with that in the first appointment.